And the first speaker is Mireille Vanpee, senior consultant and an old colleague from here from Karolinska. You have been here approximately 30 years, and you were actually here supporting us when we started the NITCAP program. And we have worked clinically, lots shoulders to shoulders with many babies together. So it's fantastic to have this combination of clinical friendship, and also scientific friendship. And Mireille, thank you very much for accepting to speak today.
Yes. Well, thank you. And I have to say that this was a really wonderful opportunity for me to learn a lot. And I've missed all of your conferences in the past, and that's a lesson for me. I'm never going to miss another, because I think what's being presented by the speakers before and what will be in the future, it's necessary. And as a fellowship director, I'm going to make the fellows come. I don't think there's anyone here from our hospital today. So we're all busy doing other things. Okay, so I see myself more as a cheerleader for breast milk use rather than an expert. I've mentioned this to Stina and the others. What am I going to talk about? Well, I'm going to try, I think everyone here, I don't have to convince you that breast milk is the first choice, human milk, breast milk for our preterm infants. But I think there's still some debate out in the world, and for me it was important to go through that again and see, okay, what are the recommendations for us today, and from there go into what Stina wanted me to do and talk more about how pleasurable feeding would occur. And that's not my expertise at all, but I'm doing a few slides there to kind of show my ideas. Okay, so the first slide here is taken from the New York Times in the States. My sister sent me this in February when it came out. Said, do you know about this? This is all about breast milk, and breast milk is wonderful. I said, yeah, thank you. That's nice. That even she, who's not at all involved in medicine, has noticed that breast milk is in the news, even in the United States, in the New York Times. So I had to take this picture, and it's all describing the microbiome that is built up if infants are not taken out by cesarean section or given a lot of breast milk. They'll have a better microbiome later, and then that also produces better health later on. And I think all of you know that, but the world doesn't know it. So we need to speak about it. So, and part of the reason there's been a controversy about the breast milk use has been the formula error, and that's already been mentioned this morning briefly, but it's there. And also the HIV epidemic, which we lived through very emotionally in the States and in other parts of the world. So that has put on a scare about breast milk. So I'm going to talk about what first. What I'm trying to convince everybody, because breast milk is a miracle, and why is it best? And then again, back to the preterm. What are the different options for the preterm? Because they can't feed, as we've heard, the same way. And we've heard that very nicely from Sophia, and then the other speakers too have mentioned it. And then when has been mentioned briefly, and how. So let's start with a goal, that is to breastfeed by the WHO and the UNICEF recommendations. This is a very strong recommendation, 2015, and it still holds. And it also specifies that breastfeeding should be supported anytime, anywhere, and it's the society's role to make that available. So going through Logan Airport regularly on my trips back to my family in Massachusetts, all of a sudden in January, do you hear me? It's changing all the time, the sound of the microphone. You hear me, okay. All of a sudden I saw this cubicle there, and I said, what is this? And it's never been there before. Last time I was through there was like in November. So this is brand new, and it's a cubicle for the mother to go in and pump and breastfeed. I think we would be shocked if we saw this in Sweden, because Sweden, you breastfeed everywhere and you don't care. But in places where that's not the same societal acceptance, I thought this was great. So things are moving. So, okay, so what about the preterm? Yeah. Is it also breast milk for the preterm? We first start with parenteral nutrition within minutes. They can't really survive without nutrients, glucose and nutrients early on. So I say minutes. It's usually like 30 minutes or an hour at the most before they really get an infusion of some sort. And they're started with breast milk in our unit anyway, within hours. And it's donor milk or colostrum when it comes, or mother's own milk. We give it by gavage and orally as well. These are all question marks because this is what we're doing, but what's the evidence and what are others doing? I don't know. And then skin to skin as soon as possible. In Uppsala, we know they do that much earlier than in Stockholm, but the principle is still the same. We want to provide skin to skin very early, and that's been mentioned, by others, by Nils too, how important it is. I didn't quite catch what was first, but anyway, they go together. Breastfeeding, feeding, mother, warmth, moisture, it all goes together. So I love nature. Yeah. And the goal is to arrive to breastfeeding post-discharge, right? That's all our goal. Okay, so what are the recommendations? SPAM in 2010, they said, the preferred food for premature infants is fortified mother's own milk. Alternatively, formula designed for preterm. That's in 2010. That's not so long ago. Then the American Academy of Pediatrics 2012 and 2017 came out strongly with breastfeeding and human milk are the recommended choices, and donor milk should be used as second choice, but under controlled conditions. So SPM rephrased things too in 2013, 2015. Yes, fresh mother's milk is the first choice, and we need to promote lactation. Donor milk is recommended as the alternative. And then preterm formula only when the others are not available. The NICE recommendations from England also, they specify more breast milk bank guidelines, and the HM-BANA also give breast milk bank guidelines on how to enhance breast milk banks development and provide it with safety and quality, which is a very important aspect for bank milks. Okay, back to the Swedish Board of Health and Welfare, 2014, we wrote recommendations, and the MilkNet, which is a network of people involved in breast milk use in the NICU, involving all different professional categories. It's very clear breast milk is the first choice for feeding all newborn infants from birth, starting within hours and to post-discharge and after discharge. Donor milk is provided if there is not enough mother's milk. Oral feeding is started within the first hours with donor milk or colostrum. Parents, of course, need guidance and information and consent to donor milk. And breast milk needs to be fortified individually for gavage feeding. Nutritional data collection should be done and steer the fortification. So it's very clear breast milk alone for the preterm infant, unless you give tremendous high volumes, which often they don't tolerate for different reasons, you need to fortify the breast milk, and you're not supplying enough things with the breast milk for the preterm infant that they need, that they receive during the third trimester, the last trimester, the calcium, phosphorus, and different things that they really need. So there's no debate that breast milk needs to be fortified, actually. So we're into the why now. Why is mother's own milk ideal? We all believe in these things, I think. I don't think anybody debates this. It protects from bacterial infection, necrotizing enterocolitis, retinopathy of prematurity. It decreases feeding intolerance, length of hospital stay. It protects long-term effects, neurodevelopmental outcome, hypertension, bone mineralization, autism, hyperactivity, and I'm sure there's things missing on this slide. But is the evidence strong? In 2015, Acta Pediatrica had guest editors, and there were a lot of authors who wrote different aspects of the breast milk and what the evidence is. And the editors kind of had an unclear message and said, well, there's conflicting results. So they left sort of a question mark if this was really, if the evidence was strong. Michael Norman from our hospital wrote an editorial then in ACTA in 2017 and a commentary, and he still referred back to this, the editors and the articles, saying that the evidence, okay, is maybe not so strong. The studies are conflicting, but if you use the grade system for evidence, the evidence is still supportive of the UNICEF WHO recommendations that I first mentioned, which includes the preterm infant from our point of view, the neonatologist's point of view. So, and that breast milk does reduce mortality and morbidity. So that's where we left it there. But then in 2017, preparing for this today, I found an article describing advances in nutrition of the newborn in Lancet, a really interesting article that brings up all sorts of different aspects, including smell and olfaction. And there's a question about long-term outcome of human milk for preterm infants still. They say very clearly, we're not really sure about the long-term outcome. The short-term outcome, okay. Neck, sepsis, okay. So there's a question mark again, and part of the question mark is due to the complexity of the processing of the breast milk we're dealing with. The mother's own milk, is it given fresh? Is it given after freezing? Is it given pasteurized? Donor milk is always pasteurized, usually. And so you're changing the milk somewhat, and you're also giving fortifications from bovine cow molecules. And an interesting article I just saw from Italy with the ones who are so good there in Italy, they were fortifying with goat's milk. Okay, they're testing goat's milk. We are more testing perhaps into the human milk fortifiers in the States. I think that's the Prolacta has done already studies on that, and that is maybe the future. We will start a study in Sweden soon, not me, Magnus Dummerlöf. Okay, so enough on that. So I think we go through these slides quickly, and I'm sorry if I shock, there's a political picture. I'm sorry if I offend someone with that political picture. But okay, necrotizing enterocolitis, I think we're okay there. It's decreased with the breast milk. Sepsis infection, yeah, I think we're okay. Bronchopulmonary disease, asthma, I think most of us would anyway agree to this, and there are new articles supporting this. And then cardiovascular disease, obesity, yes. I think most of us would anyway agree to it. And this is the political slide, I'm sorry. But I think most of us would agree anyway that breast milk does benefit neurodevelopment and maybe intelligence. ROP, he had ROP, Stevie Wonder, retinopathy of prematurity. Not everybody knows that, but yeah. So he, ROP's decreased, we think, yeah, new articles there. And osteopenia is decreased, and I just want to bring up, it's not the nutritive effects always of the breast milk we're seeing in these decreased of morbidity and mortality. It's other things going on too, the non-nutritive effects, and we can't go into that now, but once again, breast milk is a miracle with all its components, and the mother's milk, of course, being the best. So, and the benefits for the mother, let's not forget that. There are proven benefits for the mother. Okay, so what again for the preterm? What are the recommendations from the Swedish MilkNet once again? Okay, mother's own milk, fresh or after freezing, defrosting. Because if the mother's producing a lot, you need to freeze some to be able to have it later on, and then you defrost a bit chronologically to always be able to give some fresh. That's our goal. Some places only give fresh, and some places do not give fresh. I'm getting back to that. Pasteurization of mother's milk is not recommended in Sweden. Bacterial or hygiene checks are not done routinely. But for mothers of extreme preterm infants, under 28 weeks gestational age infants, you may consider taking a sample for bacterial culture at least once to have control of the mother's own milk within a short period after birth. Or what I think is more important, if an infant has a sepsis episode. We've had several episodes where group B streptococcus infection has occurred 3 times in an infant, and it's been provided through the mother's breast milk. We have been able to find that. So we had to treat the mother, of course, and it reoccurred. So that was quite a problem there. We've had serossia. I think you all know that. It can be also given through the mother's milk. And there it's very important to know about the mother's status. She had a mastitis. They had done cultures in the maternity ward. Nobody had told us, and we didn't ask. So this turned out to be very, very bad for the infant. But and we could have avoided it if we had known what the mother's situation was. So that's the take-home message there too. Always know what's going on with the mother. And then you can look into the breast milk perhaps. And then routine freezing of all mothers prior to feeding is not recommended to decrease cytomegalovirus, but we do it in terms of having milk saved for later. So the French Neonatal Society, Pierre, I don't think you were with this, but a lot of the French were with the French Neonatal Society. They say there are no good recommendations on how to use mother's own milk fresh and how to collect, store, and administer. In France, they have had the routine of actually pasteurizing mother's own milk for infants under 28 weeks, I think. Some units did not do it, but that was sort of a general recommendation, and you wanted to change that in France. And this new article came out, I think it's 2 weeks ago in ACTA. It was pre-published in February, so it's brand new. It's a great review of articles on the argumentation why to use fresh milk. So their result is to use fresh mother's own milk. It should be favored, but under stringent conditions again. This time that she needs to have hygiene around and informed how to collect, how to pump, collect, blah, 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 all that stuff. You know all that. And it has to have adequate virological and bacteriological safety. So we're coming back to that. The professionals need to, of course, give a lot of information and support. And we heard that very clearly from Sophia, how important the staff is. And that's where I depend on all my support for the breast milk in the unit, is the wonderful staff we have who are aware of these things. Okay, so just to go through quickly, the French article has two tables here on how to think. Basically, fresh milk can be given to all infants if the mother has handled the collection of the breast milk properly. If it's not been taken care of properly, if your infant is above 28 weeks, it doesn't matter. You can give it anyway without testing. If the infant is born below 28 weeks, then you need to do a milk culture and check. If the milk culture is positive, you recheck and give her more information, hygiene. And if it's repeatedly not passing the test for bacterial counts, then you eventually need to pasteurize the mother's own milk up until 32 weeks. It's specified gestational age, when the infant is 32 weeks gestational age. Okay, so what about CMV infection? There is a risk for the infants born below 28 weeks. In Sweden, we have decided there's not enough evidence to freeze or pasteurize, but in France, they consider that the evidence is strong enough. So below 28 weeks, if you're a mother of an infant below 28 weeks, you will take a mother serology for CMV. If it's positive, you will pasteurize the breast milk until 32 weeks. But you can give colostrum, because colostrum, there's very little passage of the CMV early on in the colostrum. And we all know colostrum is very special for many different reasons, which we can't really talk about. Okay, so the summary of what? For the preterm infant. Mother's own milk is the first choice. I think we're all convinced anyway, but needs to be collected under optimal conditions. Colostrum fresh is always okay. Of course, and the fresh mother's own milk, if possible, can be given, but you have to be careful under 28 weeks, and maybe different countries or different units might do a little differently there. Donor milk is the second choice and should be available, and milk banks need to follow strict guidelines for safety and quality. There's no question about that. And then once again, fortification is needed. Human fortification. So the evidence even holds if you give human milk bank or own mother's milk with bovine fortifications, you still have enough evidence for improvement of mortality and morbidity to support this. But of course, human fortification is probably the important thing for the future. So when? Okay. Am I doing okay on time? Yeah. Okay, I only have a few more slides. Everybody has talked about these things, and this is not my expertise, so I'm going through very fast. When? Okay, in utero, we know the infant can already swallow. I don't know about the suckling, but it's swallowing. And it's suckling during skin to skin, already from 24 to 25 weeks after birth. The non-nutritive sucking, it's called in the references. It can handle a small amount of oral portions carefully from 28 to 29 weeks. That's been shown in Uppsala. And then effective sucking for nutritional purposes, perhaps from 31 to 32 weeks, not large amounts, but a little bit. And then coordinated sucking, swallowing, breathing from 34 to 35 weeks. So this is more or less what the evidence is today. How do we feed? Enteral feeds, I said, from the first hours via gavage. It could be bolus or continuous, and maybe every hour is, or following the rhythm of the sleep. That is the message. And oral feeds should be started early with colostrum or fresh mother's own milk. Well, colostrum at first, obviously, or donor milk if there's no colostrum or fresh mother's own milk. It helps the cephalic phase response and the appetite hormone release and saliva and the microbiome buildup. And then skin to skin, bonding, mothers, moisture, warmth, and the other thing. Okay, so what does the Cochrane databases say? There's so much, even though the studies are not strong, the studies are not great, there's not that much out there, but then when you start looking, there are some things out there. And the Cochrane database says, well, effective oral stimulation suggests that it's shorter hospital stays. That goes against that they can learn from suckling to feeding, but this is what we've been looking at so far. Shorter time to exclusive breastfeeding, shorter parenteral nutritional needs. Okay, effective non-nutritive sucking it shows significant shorter hospital days, quicker transition from gavage to full oral feedings, quicker transition from start to full oral feedings. Totally against what, well, maybe not totally against, but it's different processes going on. And the effective avoidance of bottles is suggested. Cup feeding should be provided rather than bottle. Okay, so I can't stop without speaking first a little bit of smell, taste. Music was last year, rhythm is next year, and you already mentioned rhythm. But smell and taste is so important, so I just want to show a few slides here. Am I doing okay on time? Yeah, okay. So the olfaction plays definitely a role in enjoying food. That's common sense. We know that. We smell things good. We are really hungry. And olfactory receptors exist from 7 weeks gestational age, and they mature at about 25 weeks. This is where Hugo Lagercrantz, who's not here, says consciousness starts, because the preterm can start feeling pain and can start having these sensory mechanisms to the brain and respond. Maybe it's even earlier. I don't know if it's been tested earlier, but this is what you find in the literature. The infants have odor preferences. They prefer this was new to me. Maybe you all know this. Own amniotic fluid is preferred to other amniotic fluid. Mother's own milk is preferred to another milk. Very important for me to learn after all these years. Activation of pathways involved in digestion and anticipation of food starts the cephalic phase response, which provides then these other things going in. Increasing gut motility, secretion of enzymes, hormones, regulation of blood glucose, and enhances digestion. So all these things are important with the smell and even taste later. So gavage feeding is often provided without previous smell or taste. I think Sophia got into that a little bit too. I don't know. I don't know if you said that your baby smelled a little bit of your breast milk before feeding. No. Well, we're doing that now, I hope. I don't know. In this article from Australia or New Zealand, I forget, only 30% of the units were doing this. And this could be an easy way to enhance feed response, food or liking food. Okay, taste plays a role in enjoying food too. The taste receptors are there in the tongue, palate, throat, epiglottis, esophagus around by 25 weeks. I didn't know we had taste receptors all the way down. So that means, this GR reflex, it's not very nice. They're really tasting all the salts and all the fortifications we're giving in our gavage feeds, which we think, we're bypassing the mouth. This is fine. But we need to think, because they all have reflux and they're all getting those tastes, I guess. Prenatal and postnatal flavor learning occurs, and there seems to be very much research in the States about this now in terms of trying to support mothers to eat healthy, because we want healthier feeding habits in infants and adults later, so we avoid obesity, diabetes, which we have epidemic worldwide, actually, but in the States this is really important right now. So there was a whole bunch for infants. There's not a whole bunch for the preterm, but it appears that what the mother eats, the fetus can already recognize. What she eats during pregnancy, the infant can recognize later. There's a study, very nice study, that shows this. And if what the mother eats during breastfeeding also becomes a preference later for the infant. So breast milk is just great. So, and you can modulate. So that's the thing. You can develop the feeding behavior with ontogeny of taste preferences. You can really modulate the future responses, which is what we've talked about too. Okay, this is just an example of our clientele, besides what Sophia mentioned, and I mentioned another case before. This is a boy born 25 weeks, 728 grams, bigger than Sophia's boy. He had a lot of complications, but he went home he was discharged gavage feeding, and some oxygen, but by 39 weeks, conceptual age or postnatal age, corrected age, that's what I want to say, he was off gavage feeding. So he was feeding fine he was sucking. And then he had reflux, he had constipation, he had food aversion from 3 to 4 months of age. So he started having a failure to thrive situation. So we in neonatology contacted the gastroenterologist and the feeding team the eating feeding group who's going to talk this afternoon. Help! What are we going to do? And so the speech therapists, the dietitians, the gastroenterologists, all are working with this infant. Finally, he needed a feeding tube. Nothing was working. And he gained a little weight. And then the feeding tube was taken away at about a little later, after 1 year of age. And then he just didn't grow again and refused to eat. Wouldn't suck, wouldn't swallow, wouldn't eat. So he had to get a gastrostomy. And still at 4 years of age now, he has autism, he has language delays, and he still has a gastrostomy used for 50% of his food. So we haven't, I don't know, maybe these are things you can't really influence for certain infants because they don't feel hunger. As we've said, you're influencing the hormone structure, you're causing a behavior that you can't maybe influence, but it would be interesting if we could influence it, because that's it's a very severe case, but it's a typical case of what we see. Okay, so what are the challenges? Increasing breastfeeding rates. Renee will talk about that. We've seen they've decreased in Sweden, even though we think we're great in Sweden. Enhancing successful breastfeeding and pleasurable feeding for later. Yeah, we need to help the moms to have a good production of their own milk early on in a good environment with trained staff. And then we need to make milk available even for those who are not being able to produce with milk banks. We need the safety, we need the quality, and not the unregulated milk sharing that has started occurring. And we need to provide antenatal information. I speak to the fellows about this. You really start talking about breast milk at the antenatal discussion, and that is, I think someone else is going to talk about that, I heard. Start talking early on, because you can influence positively the mother's ability to, I can do something. Okay, and then support mothers and families, because the fathers have to support the mother. Okay, and then society's view on breastfeeding and social structure. There's a lot to do there too. So the closing remarks, I'm finishing now. Human milk for the preterm infant is the easiest way to influence for better outcomes and healthier lives. This is my pet peeve as a neonatologist. Just give breast milk, and we don't have to worry about the respirator, and we don't have to worry about all the other things. If you're already giving breast milk, you're already improving outcomes tremendously. it's so easy from my perspective, but of course, it's not always available, and it's difficult for the moms. And human milk needs to be made available to a greater extent, and not taken for granted, even in Sweden, where we think we're so great. So thank you.